Hello, everyone. This is Kent Holtorf. Pleasure to be with everyone. It's always wonderful to be in the Boston BioLife lineup. They always have just such great speakers and great information, and this whole mini series is no exception. So I was going to talk today about bioregulators and peptides, the science, double science, the science behind the biochemistry of women's health. So super science. But it's interesting. I haven't spoken on hormones for quite a while. It was such a big thing in 2009, 10, 11, for almost a decade there, and the difference between bioidentical and synthetic. And it's still standard docs say, oh, there's no difference. But we're going to look at that. Then we're going to look at a little something new on how to treat menopause and perimenopause with peptides and bioregulators. We'll talk about some underlying biochemistry of the hormones and how they work and difference between synthetic and bioidentical. I'll stay away from all the clinical side on that because I know there's other speakers there. But we'll go ahead and get started. So hormone optimization, restoring levels to more youthful levels, slows aging. You want to live better longer, right? So that health span versus just lifespan. And then what's the difference between bioidentical versus the synthetic? So we'll talk about that. And then we'll end with basically augmenting, optimizing, and replacing using, instead of the hormones, using peptides and bioregulators, which will stimulate the hormones. And it's kind of some very interesting, kind of some cool stuff. And you can use them together, again, separate. So hormone optimization, prevention of age-related diseases, including all these diseases of aging. Everyone is we're one of the worst countries, if we are the worst country in chronic illness. Like what's going on? It's certainly multifactorial, but hormone optimization as well as peptides and bioregulators can really help quell that such high incidence of chronic disease. Want to certainly improve quality of life and again, live longer, but live better longer. So here's a graph that I did in 2009, showing that when estrogen drops, it actually is dropping faster now in women. Women are going into menopause sooner, perimenopause, PMS, all those things. So this graph should be progesterone drops significantly faster than the estrogen. So you tend to be in that perimenopause period, which is generally, 10 years before menopause, low progesterone. So you're low estrogen, but lower progesterone. So you're actually estrogen dominant, but low estrogen. So really the key during that time, and it's very highly variable with the estrogen, so it's up and down, so it's somewhat difficult to replace the estrogen. But so the core thing to do is replace the progesterone, which will show not only improves, the sense of well-being and depression and mood, but also reduction in risk of cancer, chronic illness. So progesterone is key. When the difference between progesterone and progestins, you want to give as much progesterone as you can, and you want to give as least or no progestins, and we'll talk about why that is. And so you can see how it drops pretty precipitously in terms of the estrogen and progesterone, where testosterone and growth hormone, those things are more of a straight line, steady state. Well, we're going to talk about estrogen, progesterone, the bioidentical hormone. So what is bioidentical hormone? It's been around forever, but there's still such controversy because the standard societies say, oh, it's no difference. So bioidentical means identical to what your body produces, which includes progesterone, estriol, estradiol, testosterone. And then the synthetic would be something that's different than what's in your body. Now, the bioidenticals are typically synthesized. So it's like, well, how could that be? So when they say natural hormones, what does that mean? Oftentimes that the bioidentical they're synthetic, but they're not natural, but they're bioidentical. Where the synthetics, some are natural in terms of like the Premarin, which is horse estrogen, but they're not bioidentical because they're not in a human. And so they have very different effects. One of my favorite slides. So this is position statements, and you'll look at like the Endocrine Society and a picture of one of their meetings there. And just kidding, of course. There is little or no evidence to support the claim that bioidentical hormones are safer or more effective than the commonly used synthetic versions of hormone replacement therapy. Is such a stance surprising if you consider approximately 70% of these societies, probably 80% plus, funding is from drug companies? Then you have like the North American Menopause Society, which is now just called Menopause Society, as opposed to the Menopause Association, very different. And I actually, in 2009 or 9-10, hired a private investigator to trace the source of their funding and found it was After 2 years, it was impossible. They just have this huge labyrinth of nonprofits that are funded by big pharma corporations, and it's just really kind of disgusting, to tell you the truth. But so the Women's Health Initiative study, long-term study, this was a big thing. It was such a poorly done study, but it just caused this whole shift in the way people thought about hormones. But it was an expected outcome. So they took the worst hormone replacement, Premarin and Prempro, so synthetic, horse estrogen orally, which increases clotting factors. So you end up killing people off the first year. And then you add progestin to it, which increases the risk for heart disease and breast cancer, where progesterone actually reduces that. And so they found that when you combine these two, hey, you get an increased risk of, cardiovascular events. They're saying, oh, this is good for all hormones, which is totally wrong. And they say, oh, there's no difference. The proverb, there are no so blind as those who will not to see, and really fits. They don't want to see the studies that have been shown over and over. I did a review article in 2009, so it's been a while, but it still shows that the bioidenticals are significantly different and safer than standard hormone replacement. And looking at societal guidelines in terms of levels of evidence, and people always go, oh, the Endocrine Society, the Menopause Society says this. Well, how good is that evidence? If you look at the levels of evidence by the WHO and these things, they found that they are the worst level of evidence, societal guidelines. They're worse than anecdotal cases. Why? They found that they basically don't change their opinions. It's not based on actually evidence-based studies. Only 11% of recommendation consensus statements were based on high quality evidence. Half their strongest recommendations were based on very poor quality evidence. It was just opinion. So even their strongest number one, class one recommendation, which are considered dogma, repeated over and over, are supported by high quality evidence 19% of the time. And again, they don't revise them when new evidence comes out. So I have an article that I wrote, Why Doesn't My Doctor Know This? It's at our nonprofit National Academy of Hypothyroidism and Integrative Sciences. You can check the link there, but I think it's gives you all the references and the background on what we're calling, what is evidence-based medicine. I hear that, oh, we'll never know with hormones because there's no study that will be comparable to WHI. That is not evidence-based medicine. We must take the evidence that's available. And now when you look at the way they do studies, they're just huge studies that they basically can manipulate, and they do a little bit of difference with so many patients that they can make the outcome what they want. And so all these small studies, they go, oh, those aren't big double-blind placebo-controlled, cost millions and millions of dollars. When you add those together, they're much more powerful than the deception often in these large clinical trials. So you need to look at all the evidence, and more and more case studies are very powerful now, and kind of the N of one medicine with precision medicine, it really makes sense. So you want to look at all this data, right? You take it all and weigh it. And I swear there's so many drugs that come out and you think, oh my God, well, look at this great study. They turn out to be terrible. And another study, well, these studies are small. It doesn't prove anything. Damn, it's a great therapy. Yeah, it's really things need to change. And so we go, oh, I'm not going to do anything until we get this giant study. That's not evidence-based medicine. Again, you want to look at the current data and synthesize it for your patients. The WHI, again, they added Premarin and medroxyprogesterone acetate, the two worst hormone replacement products out, and they increase risk of heart attack, stroke, blood clots, and breast cancer, which was expected. And everyone's like, oh my gosh, we didn't think so. It just shows they're kind of like, believe believe their own BS. And if you take estrogen's very cardioprotective as long as it's bioidentical and not oral. If you give a progestin to that, it's going to negate any benefits, and then that's what is shown. Whereas if you do transdermal bioidentical estrogen and you typically do oral progesterone is not an issue, you'll get all the benefits without those risks. After some time, the WHI authors said a different outcome would likely have occurred if transdermal estrogen and natural progesterone was used, or if the treatments had been started at an earlier point in menopause. So they conceded the fact that, we basically gave them the worst combination. And they also started them very late. So they had significant heart disease from lack of estrogen, progesterone. And then all of a sudden you give them oral estrogen and progestin, you're going to increase the risk of clotting, hypercoagulable, strokes, you get vasospasm. So they knocked off a bunch of people in the first year. But if they would have done it differently, it certainly would have been likely a different outcome. Follow-up analysis looked at the data and they found that up to 91,000 women have died prematurely between 2002 and 2011 after they stopped taking hormone replacement because of the results of the study. So it did a huge disservice to women. And this was especially true of the women who get hysterectomy. And I see it all the time. Women get a hysterectomy, which, oh my gosh, all these OBs, if you go in, they just take body parts out, right? And you don't need to. There's so many treatments for these things, like, endometriosis and fibroids. You can treat them very successfully, but they just, let's take out body parts because that's what they do. And so no women with a hysterectomy who stopped taking estrogen in the WHI lived to age 70. I mean, that's very telling. The bioidentical hormone debate, 20 years of studies have shown bioidentical hormones are safer and not associated with the risk of the synthetic hormones, and people actually feel better with them. So here's a review article I did, really looked at every study, published up to that point, found that bioidentical hormone, we're going to look at the physiology and the clinical outcomes. And you can download this at the link there at integratedpeptides.com that published studies. There's other studies there as well. The problem is that, what we're seeing now, the suppression of truthful, which is called misinformation, but it's true. And when I was publishing this study, this review article, the Menopause Society actively tried to prevent the publication. And some of the editors of the journals are like, they told us that we can't publish it. And it's like, oh my gosh. And they say, there's nothing that we can do. And then I had a PR company at the time, and all of a sudden they said, we can't work with you. I'm like, why? They said, well, Pfizer is one of our big clients, and they said you're a conflict of interest to work, both you and them. I'm like, Pfizer is like worried about me? I'm a conflict of interest? It's really scary. It shows you like they don't want to lose a nickel out of their revenue, right? It's crazy. So bioidentical versus synthetic, small changes in structure, minor changes in structure, a difference between estradiol, testosterone, and progesterone. And we know they have very different effects. Then you look at the difference between natural progesterone, bioidentical progesterone, and Provera, medroxyprogesterone acetate. And wow, that looks hugely different. Do you expect them not to have different effects? And so when I did the review article, there's not a huge amount because they don't want to compare them, right? Essentially 4 studies looking at the efficacy. Again, we'll look more at the biochemistry of everything. But in all the studies, women that were compared head to head with medroxyprogesterone acetate or synthetic progestin and natural progesterone, women felt better on the natural progesterone and fewer side effects, improved quality of life. So they were significantly better, again, which goes counter to the societal recommendations. I'll just go through a couple of studies just to give you kind of feel for it. Fitzpatrick et al. Cross-sectional survey, 176 menopausal women. They did medroxyprogesterone acetate versus natural progesterone. And actually, in the literature, they'll use progestins and call it progesterone. So it makes it even more convoluted. So significant differences were seen in basically all the symptoms. The patients felt better. They had 30% less problems with sleep, 50% reduction in anxiety with the natural progesterone, 60% reduction in depression, 30% reduction in other somatic symptoms, 25% in menstrual bleeding. So the studies consistently also showed much less issues with abnormal bleeding, reduction in cognitive difficulties, which is huge. And normally you think, estrogen should improve the brain, but when they're synthetic, it's increasing inflammation, increasing the risk for strokes and small vessel dementia, all those things. 30% improvement in sexual function, and 65% of women felt the combination progesterone was better than the synthetic. Another study here, they compared hormone replacement with the progestin or progesterone. This is smaller, but 23 plus menopausal women found to have more negative somatic effects, including, again, less vaginal bleeding, breast tenderness. So here, another study, progesterone and synthetic progestins, generally, how did the progestin get approved? It got approved because it basically protected the uterus from endometrial hyperplasia, from estrogen replacement. But they have the same effects on the endometrial lining, but totally opposite in the breast. Okay. So the progesterone is the best way, one of the best ways you can prevent breast cancer. If you want to cause breast cancer, give them a progestin, which is in, again, Provera, it's in birth control pills and all that. So progesterone has anti-estrogenic activity in breast tissue. It also downregulates the estrogen receptor alpha, which is the one that stimulates cell division, so stimulates cell growth and potentially cancer. It induces breast cell apoptosis. So if the cells start going crazy, it basically they self-destruct, diminishes the breast cell mitotic activity, so they're not just dividing and dividing. It arrests human breast cancer cells in G1 phase, and also increase the intracellular conversion to the less potent estrogens. Where you get progestins bind to the estrogen receptors in breast tissue display, they actually are estrogenic. It's the opposite. And they increase estrogen stimulated mitotic activity. So they just like let it go crazy and stimulate it. And they increase the conversion of the weaker estrogens into the stronger, more potent activating estrogens on the breast tissue. And they also promote the formation of genotoxic estrogens. And also they will stimulate the conversion of estrone, which basically is kind of like the menopause estrogen, which is much more of a estrogen alpha agonist instead of beta, which like estriol is. Estradiol is basically 50-50, so it's neutral, but estrone is more cancer promoting, and it basically stimulates the production of that. So basically, progesterone is going to be very anti-proliferative, reduce the risk of breast cancer, where the synthetic progestins are exactly the opposite. And there's many studies showing that. So Association of Hormone Replacement Incidence of Breast Cancer, where 80,000 postmenopausal women was investigated for more than 8 years, compared with women who had never used any hormone replacement. Women who used estrogen only had no significant increase in breast cancer. If a synthetic progestin was used with the estrogen, the risk of breast cancer was 70% higher. Women who used progesterone, they had significantly lower risk of breast cancer. So completely opposite. And this is the PEPI trial. 50,000 postmenopausal women. It found the risk of breast cancer significantly increased if synthetic progestins were used. Again, this is the same review, and reduced if progesterone. A study by Chang, they looked at women prior to breast surgery, double-blind placebo-controlled. They were given placebo, estrogen, transdermal progesterone, or estrogen, transdermal progesterone for 10 to 13 days before breast surgery. The estrogen increased the cell proliferation by 230%. So again, it activates all those cells and they start dividing. Progesterone reduced those by 400%. And again, when progesterone was given with the estriol, there's no increase of the proliferation. So totally eliminated risk of breast cancer. So again, that's showing the data a different way. And then in this study, they looked at a prospective epidemiological study, oral progesterone against breast cancer, 1,083 women treated for infertility. They were followed for 13 to 33 years. The premenopausal risk for breast cancer was 5.4 times higher in women who had low progesterone levels compared to those who had normal levels. And that's what, with women that you see in your clinic, and so many women have low progesterone, and that drops faster. And so you want to give progesterone. Anyone with anxiety and PMS, it's low progesterone. And you want to give progesterone that second half of the cycle. And not only are you going to make them feel better, you're going to dramatically, according to this study, 5-fold reduction in the risk of breast cancer. There were 10 times as many deaths from cancer in the low progesterone group compared to those in the normal progesterone group. So it's crazy. It's like there's so many things that all we have to do is give, XYZ and give progesterone to women, going to dramatically reduce their risk of breast cancer, cardiovascular disease, and chronic illness. Same thing with the numerous peptides and hormone replacement, proper hormone replacement. There's so many great things coming out now for anti-aging medicine and longevity. So women also with low progesterone have significantly worse breast cancer survival rates if they do get breast cancer. PEC study, they looked at third trimester progesterone levels in the maternal risk of breast cancer. So women, when they were pregnant, dramatic reduction in the risk of breast cancer because the progesterone levels go super high. I mean, they just multiply, and their estriol level also goes way up. So another prevention. Those with the lowest quartile, so the lowest quarter versus those in the highest quarter, had a 50% reduction in the incidence of breast cancer. Associated was stronger for cancers diagnosed before the age of 50. And estriol, so people often do the biased or triest. I would not do triest because estrone is, you don't want more estrone. The estriol is a estrogen beta receptor agonist, so it's more dominant. So it's going to basically suppress the activation of the cells that would normally occur with estrogen receptor alpha, where again, estradiol is 50-50, so it does both. So it essentially is a cancer-preventing estrogen. So estradiol equally activates both, where estriol is a selective beta receptor agonist. And so it will actually compete with estradiol for the receptor. So the problem is with that 80-20 that was with Jonathan Wright study and showed, that's natural. It was totally wrong. And we find so many people, they do an 80-20. Some people do okay, but oftentimes they get hot flashes because you have this anti-estrogen in there. If you give it by itself, it actually is a estrogenic substance. But when now you're competing with the estradiol, a lot of women there just don't feel well. They're basically hot flashes, and you keep going up, but it keeps giving you more estriol. And so the 80-20 is, and it's not physiologic. And even though I love Jonathan Wright, but this study was totally incorrect. But we find that 50-50 actually works pretty well. It works much better than the 80-20. We could also give you all the protocols for that. Again, with cardiovascular risk in terms of the WHI, again, the outcome was not surprising, where the synthetic progestins, and even increasing coronary artery spasm with synthetic progestins, where estrogen will dilate the vessels. But if you give a progestin, it's going to constrict them and eliminate that beneficial effect. But progesterone will augment the beneficial effects. So we're looking at cardioprotective effects. So this is a study by Adams, examining cardioprotective effects of Premarin, which is, again, the last estrogen I would think anyone would want to use, and conjunctival acetate. So again, the worst combination. But if they use the lousy estrogen, orally even, and progesterone, there was still a 50% reduction in plaques. And it had nothing to do with the lipids, which we're finding, oh my gosh, cholesterol level is inversely associated with cardiovascular disease. So anytime you use synthetic progestin, it eliminates all the cardiovascular effects. With all these people that we look for like high FSH, LH and say, you're menopausal now we'll give it to you. That's a late effect. They should be treated much sooner. Deficiency occurs much longer. So the FSH, LH are late effects. And you can check those. Again, people, some, like if you look at fertility docs, other people do early in the cycle versus 21 days. So it's not a perfect cookie cutter assessment, but you can totally tell by symptoms, and we'll look at those real quick. Low estrogen level associated with aging. In a study, they had doctors guessing women's age. I don't know if I want to be doing that. And then they looked at their real age and their estrogen level. And they found that women who had the lowest levels of estrogen looked 16 years older than those with the highest levels of estrogen. And you can see right there just the level of estrogen and the serum estrogen level, direct correlation. And so the symptoms of low estrogen, and I won't read through all those. And also, if you want a questionnaire that we can give you that you can have the patient fill out with all the hormones that immediately, like the scale of 1 to 4 or 1 to 5, and you can see, they're symptoms of low estrogen, low progesterone, will save you a lot of time and make it easy for you. And then symptoms of low progesterone, PMS, anxiety, irritable, heavy periods, fibrocystic breast, migraines, insomnia. And we want to look at labs, generally 18th, 21st day of the cycle. One other thing, sex hormone binding globulin. So what increases sex hormone binding globulin? 2.5 things. So the level of estrogen in the liver, the level of thyroid in the liver, and sometimes inflammation. Normally, really, SHBG should be above 80. If it's low, they're either low estrogen and or low thyroid. Now, if they're on oral estrogen, just, basically first pass effect, it goes way up, which is not good. But you want to see SHBG really above 70, but above 80. And if they are low, they're either low estrogen, low thyroid, or both. And also you want to check the estradiol level. in the luteal phase, and FSH or LH, again, greater than 8 or 10. If LH is greater than FSH, start thinking PCOS. And oral estrogen, again, don't even bioidentical oral estrogen is going to increase clotting factors, binding proteins. So we'll get into peptides and bioregulators. So what are peptides? So basically, they're like proteins, chains of amino acids, but generally less than 40 to 50, depends who you ask. They become a peptide. If they're bigger than that, they're proteins. And then bioregulators are a subset of peptides that are 2 to 4 amino acids in length. So they both have very vital roles, or natural in your body, and they serve. We think of kind of like symphony of hormones controlling the body. But above that are peptides, and above that are bioregulators that are fine-tuned and are much more tissue specific. And so really the therapeutic potential is huge. And the difference between a peptide and a bioregulator, again, a bioregulator is a short peptide, 2 to 4 amino acids, by definition, because it works differently. So the peptides generally work on the cell surface. They have pleiotropic effects, so multiple effects, kind of like a supplement, but more potent. And they have secondary messengers that affect numerous metabolic processes in the cell. Bioregulators, actually, again, 2 to 4 amino acids, very small, orally bioavailable as long as they are capped, acetylated, and amidated. The body will acetylate and amidate a peptide or a protein that is important so it doesn't get broken down in the gut. So you want to make sure any peptides that you do orally are acetylated and amidated and even injectable, because the half-life is dramatically better, sometimes up to 60 times the half-life. And that's what the body normally does. The majority of peptides in the body are capped, acetylated, and amidated. So they go into the cell and then into the cell nucleus, bind to repressors or activators of genes. So they're very epigenetic. So they turn on healthy genes, anti-aging genes, anti-inflammatory genes, and suppress the sickness genes. Here it's showing they're very tissue specific. So there's currently officially with the capsid peptides like 21. We've found probably about 35 now currently available or will be available. And you see like the brain bioregulator works on the cerebral cortex. Pinealeon is actually not a pineal bioregulator, but a subcortical. Pineal works the pineal, liver on the liver. So there is some crossover, but much less than most anything else. And where do these things come from? So it was really during the Cold War with the Soviet Union, they found that their submariners, their cosmonauts, and their high-speed test pilots were aging so fast. And they're like, what's going on? These guys are falling apart. So they basically went to the military hospital, which is being run by Cavison and Pavlov, as in Pavlov's dog. It was the one who came with the study with the Pavlov's dog, but they're both KGB, and they went to them and say, you shall fix this, or, what's going to happen to you? And so they must have done something. I must have done previous work with it. And then I reading more about Pavlov. We have someone who's Russian looking through all the studies, which is interesting. And there's thousands of studies on this stuff, thousands. But most of them are in Russian. So you got to translate them, but they're more and more coming out. So what they found was that using fetal calf pineal gland and thymus dramatically reversed their aging. Okay, so this wasn't basically, they found, oh my gosh, it's so much better, but it was a military secret. So only gave it to the military and the Olympic team. The Olympic team did pretty well during that time, right? And totally orally bioavailable. So we'll go, since we're talking about, of course, estrogen, progesterone, let's talk about a couple bioregulators for treatment of ovarian, menopause, and infertility. Study design, they looked at the efficacy of the ovary bioregulator and the pineal, which is epitalin, in 214 women aged 34 to 38. All patients had reduced pineal hypothalamic pituitary estrogen progesterone axis dysfunction. And that's what we see. So as people age, people also like the whole thing with our thyroid lectures that people think, oh, the TSH, the thyroid's easy. If TSH is higher, thyroid's low. TSH is low, thyroid's high. If it's normal, it's normal. No, the overwhelming majority of people with hypothyroidism actually have low TSH because it's a pineal hypothalamic pituitary thyroid dysfunction, but it's not detected. So even though it's the most common cause of low thyroid, one of the least detected. You have to do TRH testing, which no one does. So we're working on an assay for that, actually. But the treatment group received the ovary bioregulator and the pineal bioregulator. And now with the pineal bioregulator, they had a study with 135 rats, and you can either use rats or attorneys, either one. And they were all menopausal. They gave them to them. 75% actually had started menstruating, and then 25 or so percent had live births. Like, what the heck? So crazy, right? We do it a lot for fertility. We see the anti-Müllerian hormone go up, and people get pregnant all the time. You give them T3, a little low-dose heparin, the bioregulators, and they almost always get pregnant naturally, even after going through multiple in vitro cycles and with very low anti-Müllerian hormone. And we'll look at this with the study. So they tested FSH, LH, anti-Müllerian hormone, which is the measure of the ovarian reserve. And you have so many fertility doctors like treating these women with the lowest anti-Müllerian hormone. You know they're not going to get pregnant unless they do something different. You look at before treatment, what the pineal peptide will do, bioregulator will increase FSH and LH. You think, well, okay, what's a marker for low? Well, no, it's basically stimulating, ovaries. It's kind of like giving HCG. And so it goes up and then down because as the body starts making more estrogen, then that goes down. And then you see the estradiol level was 49 before treatment. And so this is giving, again, the axis, bioregulators, the pineal and ovarian. And estrogen went from 49 to 243 and 249. Anti-Müllerian hormone, again, this wasn't a huge increase, but we see much more in our practice. And they had significantly increased follicle development. And so looking at the different hormones, so you can see the FSH, how it kind of goes up and then down. And the estradiol really is the big thing, and the anti-Müllerian hormone, the difference there. And then looking at, so all these women were women who had fertility issues and trying to get pregnant. So increased number of antral follicles, 56%, and then 98% after 4 months. And then increased anti-Müllerian hormone, 68%. And then the ones who got pregnant after 4 to 6 months, 71%. And then after 6 to 8 months, an additional 13%. Again, they were doing all these fertility treatments, not getting pregnant. After the 6 to 8 months, 84% had a successful pregnancy and birth where they previously could not with the treatment. So you can see the graphs there. So pregnancy onset, again, the 13 is really added to the 71, so 84%. Again, talking about the pineal peptide, epitalin increases telomerase and telomere length, which is a marker for biologic age. And then thymogen and the epitalin, all these genes. So you see they have some genes in common and they activate different genes, showing also Vilon with the epitalin. And Vilon's in the integrated peptides product, thymogen, alpha-1, and then the epitalin really increasing gene expression. In this, they're showing increases melatonin levels, increases bone density compared to giving IV vitamins. It also increases detoxification, and you can see the difference there with the red in the second box there versus polyvitamins didn't have any significant increase. Looking at increase in lifespan, increase in mean maximal and maximal lifespan animals consistently both thymic, again, the thymic and the pineal gland peptides with direct correlation to increased cellular immunity. So, a lot you guys have heard me before about immune modulation is huge. Reduction in cancer, because at Th1, you raise it, it's going to basically kill those cancers and chronic infections, and everyone's just chronically ill now. Their immune systems are just destroyed. And so, here's just female mice carrying the breast cancer gene received the pineal bioregulator epitalin 5 times per week. The percent of mice that developed breast cancer was 3.7 times higher in the control, so 73 reduction in the treatment group. Also, it decelerated the rate of aging of the reproductive system, with only 8% of age mice having irregular menstrual cycles versus 52% of the controls. Here's looking at cardiovascular disease by giving the combination of the epitalin and the thymosin bioregulators, where 41% mortality was lowered to 17 in patients 60 to 74 years old. And then older patients, and they actually went, that was 12 years, and then they only had a 6-year study with older patients, and they found that, again, the blue is the thymus, and the red is the epitalin, and then the combination is the pink. So from 77% in the 6 years, 41% to 28% compared with the combination. So we'll talk really quickly about thyroid axis bioregulators. We're very excited using this versus the thyroid bioregulator is great, but the thyroid axis bioregulator even better. So extracted from thyroid glands of young animals, stabilizes thyroid function. And if you have low thyroid, it raises it. If you have high thyroid, it lowers it. Also, the thyroid bioregulator will not do anything for Hashimoto's, but the thyroid axis bioregulator will. Also reduces nodules, It improves the pineal hypothalamic pituitary thyroid axis, as we talked about, prevents stem cell aging, activates telomerase, improves cholesterol levels, and trying to improve physical performance, endurance, cognitive function, mood disorders, quality of life, survival rates, cancer rates. So this study, again, not huge, but 25 patients, primary hypothyroidism, including 11 men, 14 women. And the patients, both groups, complained of significant fatigue, poor endurance, drowsiness, memory impairment, frequent headaches, dizziness, increased incidence of angina. So the low thyroid and with heart disease. The control group was prescribed the conventional T4 therapy for 3 months, and where the primary group received the thyroid bioregulator in addition. So they had biochemical testing. Compared to the control group receiving the T4 therapy, those receiving the thyroid bioregulator noted improvement in clinical manifestation of the disease in 78% of cases, and most significant effect was observed in persons in the older group with thyroid atrophy. After 20 days of only 20 days, the thyroid bioregulator group noted increased working capacity and endurance, decreased frequency, intensity of headaches, and decreased chest pain. So after treatment with T4, again, it raised their T4 and T3 levels, the low normal range, but not significantly different. It was 60% below the lowest level of normal. On the other hand, the addition of the bioregulator resulted in a 300% increase in the T3 from baseline, 40% increase over T4 replacement alone. So with T4 levels doubling and 60% higher, kind of convoluted there, but much higher levels if you give the thyroid bioregulator. So after stopping therapy, the T4 and T3 levels in the bioregulator group remain normal for 3 to 4 months. So it shows it changes gene activity, right? You can see before treatment, T3 was 24. After, with conventional treatment, 72 on T3, and then 102 with the bioregulator. T4 was 3, and then went to 4.2, and then 6.8 if you at the bioregulator. So you can see the graphs of that. So the third column is combination. The second column is just the T4. So let's talk about autoimmune. And I mentioned that the thyroid axis bioregulator is one available from integrated peptides. And otherwise, you can kind of combine the ones from like Nature's Marvel, which are also available in integrated peptides. But you can get them elsewhere as well. And you combine all those, but they're all together in one with additional thyroid bioregulators that are unknown in the general literature. Treatment of autoimmune thyroiditis with thyroid versus, again, the thyroid axis bioregulator. So 4-month study, as they looked at thyroid versus giving it thyroid axis bioregulator. Group 1, 89 patients, so a little larger. They got 50 micrograms of T4. The 42 got the thyroid bioregulator, and 87 received the thyroid axis bioregulator. Okay, so 3 groups. And study results here. So before treatment, you can see, we'll look at the ultrasound here where the thyroid axis bioregulators improved the ultrasound where the thyroid bioregulator did not. We'll look at the T4 before treatment, 0.85, the standard group, 0.92, but higher in both the thyroid bioregulator and even higher in the thyroid axis bioregulator. And then TSH, 8, and then went to 7 with thyroid treatment, but with the thyroid bioregulator to 4, and again, about the same, but the thyroid axis bioregulator. But the big difference is the anti-thyroid globulin and the anti-TPO, where it went from, before 87 and 371, which didn't really change with the thyroid bioregulator, but the thyroid axis went to 18 and 29. So significant difference. And here's the graphs on there, and you can see that on that fourth column, dramatic reduction. And then here's just a rat study that I'll just kind of glance over, but showed significant improvement in energy. And I think that's it. So anyways, thank you guys, and look forward to taking some questions, and appreciate you hanging in there through this lecture, and look forward to speaking more. Thanks so much. And thank you, Joe and Mike.